A 43-year-old young male was referred to us for suspected mass in the head of the pancreas. Our radial echoendoscope is sitting at the duodenal bulb. There was a narrowing at the D1, D2 junction. CT scan showed suspected mass in the pancreatic head. Now this is the advantage of EUS where you can see a smooth tapering stricture of the bile duct. You can see the smooth tapering of the bile duct narrowing and a dilated pancreatic duct, massively dilated pancreatic duct with multiple stones and the stricture in the pancreatic head region. So whenever we see a smooth stricture of the bile duct on EUS, we also see the gallbladder here, and we are evaluating the area of the pancreatic body. There is some atrophy there, but dilated duct seen. It's hypoechoic pancreas. You can see very, very hypoechoic pancreas with dilated irregular duct in the body and the tail. So you can imagine how well we can evaluate inflamed gland as well. Predominantly ductal disease, very little parenchymal disease, and therefore we realize that this is an advanced calculus chronic pancreatitis with inflammatory head leading to edema and the duodenal narrowing. Dilated main pancreatic duct is seen, and you can see very carefully the bile duct tapering down. Now this is the telltale sign where you see this in inflammatory head masses rather than neoplasms. Usually neoplasms will have an abrupt cutoff of the stricture. This patient does not have obvious cholangitis or cholestasis. There are some reactive nodes, but no obvious mass in the pancreas. And therefore, again, I am evaluating at high frequencies smooth stricture of the bile duct. Now, I want all aspiring endosonographers to take a note of this fact that whenever you deal with inflammatory head mass and narrowing, this is how you see smooth tapering of the intrapancreatic portion of the bile duct. And this almost rules out a possibility, and they are seeing massively dilated pancreatic duct. This edema on EUS, which is seen secondary to recurrent acute on chronic pancreatitis, has also led to duodenal narrowing, and therefore careful endotherapy was then planned without EUS FNA, as surgeon also felt that we are dealing with an inflammatory process rather than a neoplasm. So in such situation, we went ahead, we saw there were no lymph nodes. This is a duodenal narrowing. So we managed to go across the duodenal narrowing over a guide wire. So we pass a biliary dilator, and as you can see, the biliary dilator is, and then scope is railroaded over the biliary dilator into the second part of the duodenum, and then the wire is withdrawn. We prefer this technique. We can always do balloon dilatation and do that, but we feel this is a safer technique to circumvent a relatively less stenotic duodenal narrowing. So here, because of deformity, we are going straight ahead with a sphincterotome loaded with a guide wire, and you can see that we have entered the pancreatic duct, and then an almost S-shaped duct we are entering into the pancreatic duct. So before we enter deeper, here we are making a change. Before pancreatogram, we are doing a pancreatic sphincterotomy. Because of deformity, we do not want to miss out and fall out of this cannulation. So now our sphincterotome is then gently pushed over the guide wire deep into the pancreatic duct, and I want all of you to appreciate the pancreatogram here. This is the way we use it. We do not have pancreatogram initially. We always go deep inside the duct, and you see dominant stricture in the head of the pancreas. So this patient, for some reason, does not want surgery, and therefore we are offering him a trial of endotherapy here. but we aspirated the pancreatic juice and took brushing and cytology for, so we are taking the brush cytology now from the pancreatic head stricture here to make sure that we definitely rule out as far as possible any obvious underlying neoplasm. So you can see it's extremely tight stricture with dominant narrowing in the head of the pancreas with dilated pancreatic duct. So this is a pilot endotherapy, and as you can see here, after pancreatic sphincterotomy, we felt that there is a massively dilated system. Patient has severe inflammation in the head, and he has recurrent acute on chronic pancreatitis leading to duodenal narrowing. We preferred to put a 10 French Teflon stent on the pilot endotherapy protocol. So we do choose in dilated systems like this to go ahead and place a 10 French stent initially rather than going for a smaller stent, because it serves dilatation as well as very, very effective. So earlier you saw we dilated this stricture with Sohendra dilators before we plan to place place a plastic stent. So here we make sure that the stent goes across the stricture at least up to the mid body of the dilated segment of the pancreatic duct, and as you can see, the stent is pushed and you see the pancreatic juice gushing out from the side holes, and this would certainly settle patients' immediate symptoms of severe pain and recurrent acute on chronic pancreatitis. So this is how EUS, ERCP and endotherapy interface will allow us to take a correct decision on the basis of EUS findings in setting of chronic pancreatitis.